All right. Good evening, everyone. And thank you so much for joining us for tonight's event with Dr. Selina McGee. And she was going to review Show Your Lids and Lashes Some Love. I will be your host tonight. I'm Dr. Ariel Sorenzi. So I'd like to introduce our awesome speaker tonight, Dr. Selina McGee. She's the founder and owner of a beautiful practice, Bespoke Vision. It's a boutique private practice that offers patients a wide range of optometric care with its dry eye center, specialty contact lens clinic, and aesthetics suite. She is the first OD in the country to perform neurotoxin injections and laser resurfacing. She performs RF, IPL, and surgical lid procedures. She is a renowned national and international speaker. She is an adjunct assistant professor at the Northeastern State University College of Optometry. She currently serves as president for the Intrepid Eye Society, trustee on the SECO board, and the Board of Examiners in Oklahoma. She is a fellow of the American Academy of Optometry and diplomate of the American Board of Optometry, and is past president of the Oklahoma Association of Optometric Physicians. Here are some of her financial disclosures. And all financial relationships have been mitigated. So I'm going to have you take it from here, Dr. Selina McGee. We're super excited to hear from you tonight.
Thanks, Ariel. I appreciate it. And thanks, Dr. Wu, for having me on. And I'm so excited to be here with you guys. So I thought I would give you some background for those of you that don't know me. I think it's really important just to kind of understand how all of our minds work and the intentionality behind what I do and why I do the things that we're going to talk about tonight. So this is my practice. I decided to build a building during an epidemic or a pandemic. So just a little word of advice: if you're going to do real estate, make sure it's not during a pandemic. But it took about 12 months longer than we thought it would, but here we are. We've been in the practice for 18 months at this point. But whenever I moved, I rebranded. And a lot of people ask me why I chose the name Bespoke, and patients actually ask me that almost every day, and they ask my team that every day. And I was really intentional about choosing a word that reflects my brand. It reflects how we take care of patients. It reflects our core values. And bespoke actually means something that's customized. And that's exactly what we offer to our patients, is everything that they do the second that they engage with us, whether that's on the website, whether it's on a phone call, once they make it into the front door and cross the threshold, it's all about them, and it's customized to what is going on in their lives. And that's why I've really pulled this whole dry eye thread along with aesthetics and along with the things that we're going to talk about tonight, because our patients want to put their best faces forward. And this is a big part of what we all do, but sometimes we don't recognize exactly what it is that we do and the way that we do it. And patients don't always recognize that either. So I thought I would just share a little bit of my background and what my practice looks like today. I have been practicing for 20 years. So this is not how I started. So if you're at the beginning of your journey, then I did aesthetics and all the things in an exam room and 2 lanes, and now I have 5, but in this beautiful building. So start where you are, and the things that we're going to talk about, you can implement tomorrow. So let's jump in and we'll start to talk about how to think differently about optometry. And so I call this Optometry 2.0. And I want to ask the question, what is comprehensive eye care? What does that really mean to you? Because it's very different than what it was 5 years ago, 10 years ago, 20 years ago. And we all do the things that we learn in optometry school. We treat glaucoma, we treat dry eye, we diagnose and co-manage cataracts, all those things that we do. But I want us to start outside and then work our way in. And so that's what comprehensive eye care really is, because there's lots of things happening the skin around the eyes, the mid face, the top of the face. All of that affects how our eyes look and how our eyes function, and it affects the ocular health as well. So I want you to think a little bit differently about what comprehensive eye care means in 2023. And, this Venn diagram, I think, represents it really well. And yes, we're giving people their best vision. And I have a high-end optical. I do specialty contact lenses. We have a pillar inside of our practice of presbyopia. And I always think of my practice as having pillars. And I never want to have all of my practice standing on one pillar, because if something happens that I can't control and that one pillar goes away, then my whole house falls down, right? So I always think about having pillars. And for me, that's been high-end optical, again, especially contact lenses, presbyopia. Of course, primary care is what feeds all of these subspecialties. We have a dry eye clinic, we do myopia management, and then this whole aesthetics piece that we've started to build, where we offer radio frequency, intense pulse light, laser resurfacing, and also neurotoxin. And all of those go together. And then I intentionally left this whole bottom section because who knows what tomorrow brings. And that's what's really exciting about what you and I do, is there's so much opportunity. And I left that blank on purpose, because who knows over the next 5 or 10 years what we're going to discover in optometry. So specifically tonight, we're going to talk about what is your lid and lash strategy. Do you have one? Because I know you're behind the slit lamp and you're looking at things and you're like, oh my gosh, what is happening here? I think I know, but this patient's not even going to ask me. I need to say something. How do I have this conversation without insulting someone? Do I have this conversation? Is this relevant? And I'm here to tell you it's extremely relevant, and you're going to discover why. And you all know this, but I think the conversation is sometimes challenging because you don't know how to bring it up. And we're going to walk through questions, and we're going to really simplify this because it can get overcomplicated quickly. So again, tune in. We're going to have some fun tonight, and I'm going to make this really interactive. So I want you guys to put your questions that you have as we go in the Q&A box. And then I'm going to give you questions that's going to drive our conversations as we go, also in the chat box. So let's jump in. So I'm going to ask now, how many of you have a lid and lash strategy that you talk about consistently, that if I walked into your practice today, one of your team members could tell me the strategy, and you could say, okay, here's what I say to every patient, and this is what I offer to patients, and here's my prescriptions and my recommendations. So if you have that, put that in the chat box. Say yes to that. No, I'm working on it. I'm super curious what you guys are out there doing, and where your challenges are. Okay, I love it. Okay, tuning in. No, I'm working on it. Yes, yes. Nope. Perfect. So let's jump into clean eyes are healthy eyes. And keeping our lids and lashes free of debris and bacteria helps relieve and prevent many of the bacterial triggered eye concerns. And we're going to walk through all of these. Of course, dry eye and meibomian gland dysfunction, blepharitis. The big one that I get so many questions on is eyelash extensions. How do we teach patients to care for those? How do we teach them best practices? We're going to talk about contact lens discomfort. And then, the rise of styes and chalazia over the last few years, ocular rosacea, we're going to talk about, and then of course, Demodex. So all things that happen on the outside, and then we're going to work our way in. Okay. So how many of you behind the slit lamp, this is what you see? So this is when your eye exam starts. And notice that what we're looking through here is a keyhole, right? So this really is the window to the soul, but we have to back way up, because if we get so focused right on this area, we're missing all of the forest for the one tree. And everything that you and I do to treat what we see in this picture is going to be affected by what's happening on the outside. And so I want to encourage all of us, your eye exam starts the second that you actually walk into the room and you observe how the patient is sitting in the chair. Do they have a head tilt? Or is their chin forward because they're looking underneath their eyelids? Look and notice those things. Look at their skin on their cheeks. Do they have telangiectatic vessels? Do they have rosacea? That's when your eye exam actually starts. So outside looking in, this is the last thing that you're going to look at, right? So let's talk about, what do you see when you look at Ryan Gosling here? Somebody put in the chat box, tell me something that you notice about him. You walk into the exam room. What's the first thing that comes to top of mind when you walk in? Put that in the chat box. Leftosis. Perfect. See, you guys are like a stellar group. Exactly. So he has leftosis, and guess what? So do a whole lot of people. And we now have lots of solutions to help patients with not only the health and how to keep their eyelids healthy, but also the way that the eyelids look. And so I think this is a really important one that we don't want to overlook. And so this is something that I am constantly on the lookout for. So great, you guys are already like batting 100%, 1000%, depending on how many questions we have. Okay, so what do you notice on this image? And remember, this is a picture of the back of the eye, but we're starting at the front. My striations, yes, true. So if you have your technicians, and I'll walk you guys through this. This is actually the upper lid, right? So have your technicians, if you do wide field photography, teach them that, hey, by the way, if I have to actually use a Q-tip to lift the lid to get the appropriate photography that I need and that you need in the clinic, they have ptosis, right? And it might be dermatochalasis, it might be blepharoptosis, but this is often the first place that this conversation can start to happen. And as I'm going through the exam, yes, I notice before I even sit down in my exam chair to talk to the patient, but as we're going through, and this just reiterates why it's so important to talk about lids, because they're limited on what they can see because their eyelids are actually in their way. It's limiting how much light is coming in. If this patient, for example, had macular degeneration, they need as much light as they can get. And so it's not always an aesthetics concern when we're talking about blepharoptosis and dermatochalasis. So I think this is a really good example of something you and I do every single day, just looking at it from the outside in and thinking about this differently. And then the other thing that is another picture on here that we're looking at is, yes, we're looking at meibomian glands, and I apologize for the meibomian gland part because you can't even really see that. But I'm actually more interested for this topic of what's happening with the upper lid. And here's another example of, we're looking at meibomian glands, but what else do we notice? This patient's got dermatochalasis, they've got blepharoptosis, we've got skin literally sitting on the eyelids. So this begs us to have a conversation around, have you noticed this? Do your eyelids bother you? Have you noticed that you don't see as well at night? Lots of things are happening here that you guys can ask great questions to open this conversation wide, much broader than just looking at, I'm looking at your optic nerve and your retina and your macula, and also I'm looking at meibomian glands. There's so much here that we can educate with patients. So again, it's just thinking differently and having that conversation. And let's just do a little lid anatomy refresher. And for those of you that are needing continuing education and needing CE questions, this is probably a good one to know. So lid anatomy, remember the two muscles that lift the eyelid, the levator and Mueller's are the two muscles that lift the eyelid. And we now have a drop that you and I can prescribe to lift the eyelid. And we get market elevation within 15 minutes, peaks at 2 hours. It can last anywhere from 6 to 8 hours, depending on the patient. But this is one of my patients that just is an example of lifting that right eyelid. So we've got before, and then we've got 15 minutes later, just in her right eye. So this is a great way for us to step into this space and have something that's a non-surgical option to help patients with blepharotosis. So another option is doing radiofrequency. And this is a non-surgical treatment where we tighten and build collagen, and we're building elastin too. So what that does is it tightens lids. You can, because you're building collagen, you're widening actually the fissure. And so you can see on this patient that her MRD increased. So this is another option for patients if they want something that's non-surgical, maybe they don't qualify for surgery yet, that can actually prolong blepharotosis surgery. It treats periorbital fine lines, lateral hooding, dermatochalasis, ectropion. A lot of docs are actually doing it for meibomian gland dysfunction off-label, but because you're rejuvenating that skin, it can help with the blink. So this is another way to step into treating eyelids. And then of course, let me go back for just a second. There's a third piece to that. The example of the patient that has lids touching lashes, that's a surgical case, right? Their medical insurance is actually going to consider that a functional problem. So they're going to have their insurance be able to help them with that. That's not a cosmetic surgery. It's a functional surgery because we're impinging on their visual field. So the third piece to this is maybe it is a surgical consult that you can absolutely co-manage. And I know probably every single one of you on this webinar tonight co-manage your cataract patients, but I would be curious as how many of you co-manage your oculoplastic patients. And I would encourage you to do that because you absolutely can. You can still bill the same code. You can use the same modifiers. You can bill the 20% of what that surgery is, and you can do all of the co-management and the follow-up. You can do the pre-op as far as visual fields. There's lots of ways to do that. So think about co-managing oculoplastics just like you co-manage with your glaucoma surgeon and your cataract surgeon. Okay. This is a fun game we're going to play as we go. I took a trip about a month ago with my family. I've got two daughters who are 10 and 12, and my husband and I took them to Colorado. So we were in the car for about 12 hours. So there's, plenty of time to do things, iPads, card games, just chatting, music. But we went to the old version of I Spy. Even at 10 and 12, we still did that and had a lot of fun. So when I was putting this lecture together, I was like, you know what, let's just play the same game. So what do you guys see when you're looking at a lid like this? So back to the chat, tell me what you see when you're looking here, right? And the first person got it. So collarettes, which is absolutely pathognomonic for Demodex. And you guys are already so in tuned. I mean, you've got lash dropout, right? You guys are all seeing that thin, sparse lashes, matarosis, lashes that are misdirected. They're growing in the wrong direction. And we've all had patients that say that, my lashes just don't do what they used to. They grow in funny directions. They're brittle. And I just don't like my lashes. So you guys are spot on. You're absolutely seeing Demodex because we're seeing collarettes, and that's all you need. We don't have to have a microscope to pull a lash to look to see if there's Demodex. We now know based on studies that when you see collarettes, you absolutely have Demodex. Okay, so we're going to talk about that a little bit more, but I wanted to give you one more picture and play the game of I Spy, I See. What do we see on, I fast forwarded too fast for you guys. So what do you guys see here? Pterygium. What else do you see? That one's the obvious one, right? So same thing, lash loss, lash dropout. How many of you knew that Demodex blepharitis can cause and contribute to a pterygium? What else do you guys see on here? Do you see skin touching lashes on that upper lid? Do we see pigmentation along the lower eyelid margin? And do you talk to your patients and say, did you know that the most common place on the body to get skin cancer is on your eyelids? And when they look at you and go, what? What do you mean? And I say this behind the slit lamp, and they back up and they're like, what? And I ask them the next question of, have you ever put sunscreen on your lower eyelids? No, is the answer to that, because guess what? It burns. So that leads us into a perfect conversation of, you absolutely have to have good ophthalmic sun lenses to protect your eyes. This is sunscreen for your eyes. The reason that we get skin cancer in our eyelids so commonly is because it's overexposed, because we can't put sunscreen there. And the skin there is delicate. It's 0.5 millimeter thinner than anywhere else on the body. So all of these questions drive back towards that eye health, but you guys are spot on perception wise. So let's talk a little bit about Demodex. And Demodex mites can cause damage in 3 ways: mechanical damage, actually irritation, keratitis, and like we talked about, eyelash distension and loss; chemical damage because of their production of cytokines, chemokines, other inflammatory biomarkers, and they can alter the meibum composition and cause inflammation. And then absolutely bacterial damage, because they can transport bacteria through the mite. And when you get an overgrowth of bacteria, you can get an overgrowth of Demodex. And I saw somebody put in the chat, one of the comments was, I would love to have something that actually targets Demodex specifically. So currently, IPL will target Demodex specifically, at least on the surface, because the way that intense pulse light works is we're using selective photothermolysis. It's a big fancy word for, we're targeting a very specific chromophore, which could be pigment or could be oxyhemoglobin, which is redness, right? And we're lysing that cell by using a particular wavelength. And it just so happens that with Demodex, they absorb the wavelength of light just like our melanocytes do with the melanin in them. And so we can actually barbecue the little critters with intense pulse light. Tarsus is a company that has filed their NDA for a product called TP-03 that they're expecting a PDUFA date of around September that shows eradication of Demodex. So stay tuned for that, because we may have a solution that will eradicate. And let's talk about how we look at patients. So we've talked about walking into the room, looking for head tilts, looking for funny chin positions, and just looking at skin in general. So when we get behind the slit lamp, what should we do other than look straight on? What's the next thing that we should do? And you can see it on the left picture. That's what I'm doing. I'm looking pretty much straight on. But in the right picture, what am I having the patient do in that one? What's super key? I'm having the patient look down, and it literally only takes 1/1000th of a second. But when they look down, look at all the stuff that I just uncovered. We've got telangiectatic vessels all over the place. This patient has florid ocular rosacea. They've definitely got Demodex and collarettes. There's who knows what kind of bacteria and biofilm living in all of that. And we would have completely missed all of that had we just looked at the patient straight on. And even in this picture on the left, what do we see? Lashes, again, growing funny directions, matarosis, we're losing lashes, but we can see it even better in that right picture. So I want you tomorrow, here's your second challenge. First challenge is look for opportunities for looking at lid structure, whether it's when you walk in the room, whether you're looking at wide field photography, you're looking at meibography, you're just talking and having a conversation with the patient. There's your number 1 challenge. Number 2, I want you to start to lift and have the patient look down. And I want you to get really comfortable doing this and make that part of your normal routine. 1/1000th of a second is all it takes. And you're going to uncover all of these things that we can miss. So have the patient look down. Okay, this one's going to be really fun and we might be here a minute. So what do you see when you have a patient behind the slit lamp that looks like this? And granted, this is a lot of things, but I wanted to have a very in-depth conversation to get people comfortable with what is happening here. And for my audience members that don't know the difference between eyeliner, mascara, eyeshadow, I'm going to walk you through it real quick. So everything that you see in color on the top lid, the green, the peach, the purple, all of that is eyeshadow, and all of that glitter. So the sparkly stuff that you see is a problem. So glitter is tiny little pieces of plastic that have been painted, and there's different sizes of glitter. And the FDA considers glitter to be actually a food product. So they don't even manage this. But what do you think happens when all of those tiny glittery pieces get into the meibomian glands or into the orifices, right? That's a problem. So there's big red flag number one. Mascara is what goes on the eyelashes to make them longer, darker, make them look thicker. And then eyeliner is what you actually see in that like real sky blue where they've painted right over the top of their meibomian glands. So that's a huge problem. And that's what people call water lining or tight lining. And I like this example because the blue makes it really easy to see. A lot of people, most people don't wear blue. You're going to see black caked on there. But when you show them that they're covering up all of their meibomian glands by doing that, and that this is a big problem, that's how you can start to have these conversations. So I wanted to walk you through just what each one is for those of us that aren't, putting this on our faces every day and might not know. But here's the reality. All of those cosmetics, and this image came from TFOS DEWS 2 and the workshop that was done in 2017. When you look at what causes dry eye disease and this vicious cycle that happens, you have desiccating stress, and now we start to produce inflammation, and that inflammation continues to drive a decrease in the lacrimal gland, a decrease in how the meibomian glands work, and it just becomes this vicious cycle, right? There are multiple places where cosmetics happen. We can have an unstable tear film. It can cause blepharitis and lid flora problems. It can absolutely affect contact lens wear because they're filled also with preservatives. And it can cause inflammation, lacrimal obstruction. The other thing that glitter sometimes is made out of is something called mica, which is actually a stone. It's like little tiny pieces of ground up stone that wind up in the whole system. And then again, contact lens wear, refractive surgery, all of those places are where cosmetics can affect and enter the realm of dry eye disease and cause this vicious cycle, which causes goblet cell, mucin loss, epithelial damage, and apoptosis of the epithelial cells. So how do we talk to patients about this? What do we tell them? What's in the literature? This is what's in the literature on toxins in cosmetics. We are all wildly familiar with BAK, right? It's a preservative. We know what that does, but it's also in lots of cosmetic ingredients. And one of the places that it shows up frequently is in those little eye remover wipes. So watch that. And it's typically at about 1,000 times concentration higher than what you and I use in any of our glaucoma drops or any of our drops. And we know what that does to the front surface long-term. So imagine if you're a patient using that to take your makeup off at night, every single night, and you're the doctor on the other side going, why isn't my dry eye treatment working? What is happening? I don't understand. These can be a lot of your culprits. And so this will sabotage your best efforts if we don't have these kinds of conversations. So these are the things that we know in the published literature that we need to have patients avoid. And these are things that are in your handout too. And I just give patients this. It's really challenging for you and I to know all of the things. But if we give patients resources and say, here's the things to avoid, look for this in your products and make sure that they don't have this in it. This is a big one. We're going to talk more about number 5, which is isopropyl chlorprosonate. So I'm going to save that one. But again, this is in your handout. So utilize that. Some other just industry shocking things that patients aren't familiar with. And when I tell them this first bullet, that the laws that govern the cosmetic industry, the FDA has not touched since 1938. They are like, I'm sorry, what did you just say? And it's amazing that we have 11 ingredients in the US that are banned versus 1,300 in Europe. There's about a little over 1,000, I believe, in Canada. So we're very, very lenient is the point to this. And patients have to be really diligent about the harmful ingredients because there's very little, if any, regulation. You cannot trust the label. You have to have patients start to read those themselves. And, you know, really good, because I know you guys are gonna ask, there's a couple of places that patients can use. So one of my favorites is the EWG app. That's a great place for patients to use. Skinsafeproducts.com is another good website that you can get good information. And then the EcoWell. So those are all 3 things that can help you help your patients. Okay, so we talked about cosmetics. Let me just check. Okay, perfect. So what do you guys see here? Redness, right? So what happens when the patient says, I just use Lumify every day. It's over the counter. It's fine. Really? So FINE stands for feelings I'm not expressing. That you can use in clinic and at home too. I promise it will help you in your conversations with your teenagers, your spouse, whoever. FINE does not mean fine. Feelings I'm not expressing. But we have to dig deeper. Why is this redness happening? Can the patient use Lumify? Absolutely. But we need to identify and understand what's happening to cause the redness. And so this is a great question to ask. Are you using any kind of over-the-counter product to make your eyes feel better or make your eyes look better or make your eyes whiter? Whatever you want to add in that question makes total sense because patients won't tell you this. It's over the counter. They think it's not a big deal. I actually had a patient, he's not in this slide deck, but he was using a bottle of Lumify, an entire bottle every day. So you can imagine what his ocular surface looked like. So patients will abuse and overuse these as well. So it's a really important topic in conversation. And I want you to teach patients that redness equals inflammation. We have inflammation that's going to and is causing a problem, and we have to address the underlying cause of what's happening. So here's some more fun pictures. What do you guys see here? And these are kind of they're both a little tricky, actually. Yes, so extensions, squamous bleph, flakes, all kinds of things, right? Blepharitis, yes, nastiness, I love it. So you're exactly right. And the left picture is actually just false eyelashes that are glued on. So a couple of things let's talk about there is the actual glue typically contains formaldehyde, which we do not want on the front surface. That's a known offender. And typically patients will wear these 5 or 6, 10, 15 times, who knows, but it's usually more than once because they're fairly expensive. And how do they actually clean the lashes when they take them off and then glue them back on? So that's one thing that you will see at the slit lamp. And then you're exactly right. You've got, of course, extensions here, but if they've just had extensions put on and they're the natural looking ones, you can miss this if you don't have patients look down. So this is just another reason to get patients looking down and look at all of that telangiectatic. What do we see? Redness. We have inflammation. We've got Demodex. We've got bacteria, all kinds of things happening at the base of those lashes. And I will tell you my experience initially with teaching patients how to clean their lash extensions consisted of a patient walking to the front and saying, well, that sounds really good, but I'm going to have to ask my lash girl if that's okay. And right, that's like it was like a knife in the heart. Like, I think my heart like pitter pattered and like stuttered, like, oh my, we have lots of work to do here. If we're taking the advice of a non-professional, and you and I have a microscope, we're looking at this every day. So these conversations are essential to what you and I do. So you're exactly right. So let's talk about extensions. This is a whole process of gluing single lashes to the anatomic lash. They fill and redo these about every 2 to 4 weeks. And the glue solvent and the fragrances wind up on the ocular surface. They're typically, again, filled with formaldehyde. And how do we teach patients to care for eyelash extensions? Because they always ask, and I know that's going to be one of your questions. And I used to have maybe 1 or 2 patients a week, and then it's been like 1 or 2 like every hour. And I'm starting to have a less than I used to, but it's still very commonplace. And they're notorious, right, for that buildup of oil and debris and that bacteria, as well as Demodex, because now you've got bacteria that attracts Demodex. So, and many of these extension wearers, just like my patient said, oh, I'm not going to do anything because I don't want to mess up the glue, because that's going to make my extensions fall out. And I just spent $300 getting these done, and they're going to have to be filled in 4 weeks, which is another $175. And I need to budget for this. And my solution to this is hypochlorous acid twice a day. So use your hypochlorous spray twice a day along with a clean lash brush to keep the lashes clean. But guess what? When you clean them well, they last longer. But hypochlorous spray is how I answer that question, along with a good lid cleanser. And I like a little brush to really get into the base of those lashes. We all know these extension complications: itching, redness, pain, heavy eyelids, contact dermatitis. I mean, that's what this patient has. She was allergic to something in the glue. It's really common. Toxic conjunctivitis, conjunctival erosion, allergic blepharitis. Yes, yes, and yes. Patients often come to us with these kinds of complications, and they don't want to take them off. And so in this patient, we educated. Some patients do choose to take them off once they've been properly educated, but the others, they say, okay, well, what can I do to make sure that this doesn't happen? I'm not giving these up. And hypochlorous spray is one. And then if they have an allergic reaction like this, I will do a steroid to get this calm back down, and then have them research the glue. And they can do a little, allergy test on the inside of their wrist to see if they're allergic to the glue. So that's a great conversation around eyelash extensions, again, because they have these formaldehydes in the glue, and that's actually the problem with these high formaldehyde emitting products. There's mechanical consequences of this: lag ophthalmos during sleep, collection of bacteria under the lash bed, but we can handle that, right, with hypochlorous spray. Constraints to physical hygiene and cleansing of the lids. They don't want to touch them. They can't get in there. That's why I like the little brush. And then calcification of the lash base. And a lot of these have, preservatives that aren't healthy for the front surface. But this just blows me away. I mean, on no planet does this actually look good. I mean, you've got so much redness, so much debris. The lashes are actually crooked because their natural lashes crooked. So we just have to have these conversations with our patients and teach them the best things possible. Don't give up if you have patients that say, well, I'm not doing anything different. I like my extensions. I'm not giving them up. Choose your battles, educate, and then it's up to the patient to continue to make that decision. But at least you have given them all of the knowledge. The other thing that I teach patients is take breaks. So when they go back for a fill, take a break for 4 to 6, 8 weeks before you put them back on. That's another really good practice, is just take a break with them. Okay, so next I see, what do we see here? What do you guys think this patient's been utilizing? Lumify, Latisse, prostaglandins. Man, you guys nailed it, right? A PGA. I mean, you see all the things. She's got that involutional deep set eye because she's dissolved, and she's got fat atrophy, the hyperemia, the long lashes. I mean, you can spot these patients a mile away. You know that they're either doing their glaucoma drops as they should, or they've got something over the counter that we need to have a chat about. And, you know, I had a patient recently that was a self-referral into my dry eye clinic. And the first thing I noticed when I walked in, and I asked her, I didn't even need the microscope. I asked her how long she'd been using a Lash serum and which one was it. And she goes, no one's ever asked me that question. And I've been suffering for almost 10 years based on her history with dry eye. And she'd kind of moved from place to place. And it was one question, and we stopped doing that. And luckily she does have some meibomian glands that are left, but she's done a lot of damage over the years and had no idea because she was using something that was over the counter. And we talked about earlier that we were going to expand this. So let's dive in. Latisse is the only approved FDA lash serum. The active ingredient, of course, is bimatoprost 0.03%, but there are many synthetic prostaglandins on the market that you don't need a prescription for. It didn't have to go through the FDA because it's a synthetic prostaglandin. So you're going to look for that ingredient, isopropylchlorprostinate. And when you see someone that has a natural looking, very long lash, you're going to ask the question, what are you putting on your lashes to make them look like that? Are you just lucky? Good for you. But tell me about, is there a serum, anything you put on? And you're going to be wildly surprised what comes to light when you have those conversations, because we know it causes ptosis and ophthalmos, inferior scleral show, just like that patient before. Fat atrophy, involutional dermatochalasis, meibomian gland dysfunction, hyperpigmentation, redness, pruritus, all the things. So just my biggest takeaway with all of these conversations is it really is as simple as asking the right questions and just ask one more question. And you're going to uncover tons of things. So this one, what do you see here? What do you guys think? Ocular rosacea, absolutely. All of those telangiectatic vessels, completely unnecessary. 20% of rosacea starts out on the eyelids. Ocular rosacea, 20% of the time will precede facial rosacea. So sometimes you and I are the ones having this conversation for the first time with the patient. We also see a lot of bacterial overload. We see Demodex there, lashes that are missing, lots of things happening on that eyelid, right? And so my biggest thing that I have used for the last 5 years is intense pulse light to help me with ocular rosacea and patients that also suffer with facial rosacea. I utilize it, and I put this picture in here because I also utilize it for chalazia treatment, which we know when we have an overgrowth of bacteria and Demodex causes chalazia hordeola and can exacerbate these conditions. And so I use IPL. I practice in Oklahoma, so I can do injections, I can do surgery, but I like to offer something that's non-invasive, and patients are very appreciative of that. So I use IPL all the time to treat chalazia and hordeola. Okay, what do you guys see here? SPK, absolutely. Staining. You have poor tear lake. You're exactly right. And you have to stain these patients. So every single patient that walks in, you've got to use Vital Dye. If you are in a beginning dry eye clinic, if you do refractions, if you fit contact lenses, if you're doing co-management for cataract surgery, if you're doing oculoplastics, if you treat glaucoma, any and all of those things, right? And that's bottom line is we all do that every day. we have to look at the corneal surface and we have to stain, because it's going to uncover a plethora of things that we will miss and blow right by. And it has to be with a fluorescein strip. Fluoresce is too thick. You'll miss this fine punctate staining. And I love to use my Ratten filter that I use for fitting GP lenses or looking at staining patterns with sclerals, either one. I use this on the cornea too, because it lights up like a Christmas tree. It just makes my job that much easier. So I can see that desiccating stress on the front surface. So I think it's super, super important. You do not need all this fancy equipment to be able to have a dry eye center. You need your slit lamp and your vital dye and a great questionnaire and your fingers to push on the meibomian glands so you can see what's happening with those. That is all you need. Of course, you can add things down the road to start to offer more education and do more therapies in office, but that's where you start. But every single patient, and imagine that this is your patient who is now on their immunomodulator, tears, and let's say they've done a steroid maybe once or twice, and we're on month 4, and the patient looks the same. They look just like this. And we haven't asked good questions, and we take a step back and we go, okay, what are we missing? What is happening here? I've missed something. Maybe we didn't have the patient look down. Maybe they've got florid blepharitis. That's an easy fix, right? Then we can talk about lid hygiene, and we can talk about cosmetics. Maybe they're actually using one of the over-the-counter serums to help with their lashes. Those are all things that when you see patients like this that you're treating and it's not working, take a step back and go, okay, what did I miss? Maybe it is hygiene and the things we just talked about. Maybe they actually have early neurotrophic keratitis and it's a whole different process. But ask the right questions so that you uncover and get in the habit of asking those questions early, so you don't get frustrated with patients not improving in the way that we think that they should and can, because they're sabotaging your best efforts unknowingly. And then what do we see here? Contact lenses. What do we see on the lid margin? Telangiectasias. This patient, absolutely. This patient's got rosacea and a contact lens. Our patients want to be able to wear contact lenses longer. When you look at the contact lens dropout rate, it hasn't really changed in the last 20 years. And there's a lot happening on the ocular surface. And we have study after study that shows us that when you have bacterial overload and you have Demodex overload, that it affects contact lens comfort and wearability. So super key important component of when you fit contact lenses, that you're having a conversation about hygiene and how they have to care for their eyelids so that they are a successful contact lens wearer. And then what do we see here? This one's a fun one. MGD, right? This is super obvious. And you're seeing telangiectatic vessels underneath. Look at all these lashes missing, matarosis, misdirected. And this is just the patient just sitting there. What happens if we try to push on that? A whole lot of nothing, right? So the other key component of looking through your exam is making sure that you're pushing on the gland so that you know diagnostically what is coming out of that gland, and then record it, because all of this ties back to meibomian gland dysfunction. And when you look at bacteria, they create this biofilm that sets off, again, this whole cascade of events. So ways to manage, and we'll stay on the MGD thread for a moment. There's 6 different things that can cause meibomian gland dysfunction. And this was a paper that was published in 2017. This was called the Ocean Group that looked at this. So think of this acronym BESTO: bugs, enzymes, inflammation, stasis, temperature, and obstruction. Any one of those is going to cause meibomian gland dysfunction. Sometimes patients have all 6. So how do we address this with patients? And I love this slide that Laura Perryman put together. looking at what we have available for us, and we treat the besto. And I initially, when I started thinking about this and doing this different in my clinic, I would actually put BEISTO in the chart notes, and I would make sure that I had addressed these. And you can easily address bugs, enzymes, and inflammation with a hypochlorous spray. You know, when you prescribe an immunomodulator, then you're going to treat enzymes, inflammation, temperature, and obstruction, and hyperkeratization. IPL happens to do almost all of it really well. And then we talked a little bit about TP-03 and that, you know, coming down the pike. So there are lots of ways to manage this, no matter what kind of technology you have, but knowing that those 6 pieces we have to address, and we can do it with an omega, we can do it with hypochlorous spray and immunomodulator if we don't have devices in our clinics. So also, when you look at TFOS 2 that came out in 2017, when you look at the steps of what's available, when should we be talking about what? Step 1 is always education around ocular surface and dry eye disease. But look at the bottom bullet there that I've got highlighted, lid hygiene, warm compresses of various types, but lid hygiene is something that every single patient that walks out of our clinics should know how to do. You know, we talked a little bit about IPL. That's actually in step number 2, along with prescription medications. So here's the questions to ask, because these can be intimidating conversations if we don't know how to ask the right questions. This is also in your handout. So I love having this readily available, and I sprinkle this throughout my exam. Some of these questions are on my intake questionnaire, and then some of them are just a conversation that I have with patients. And then some of them happen when I notice something. So asking these kinds of questions are a great way to open up the conversation, where the patient really, you'll see them lean into, oh, good, there's someone I finally can talk to about this because I don't know where to get good information. You're going to be really surprised by how well these conversations go. Start the conversation young. Don't be afraid to ask patients about their beauty practices. And so initially, when I started having these conversations, it was specifically with women, but men use a lot of products around their eyes too. Soap, you know, and some of my patients are using like bar soap and stuff that's really not good for the lids. It's really stripping. And then I've started having these conversations with kids too, because I want to be seen as the person who gives them the correct information, not the latest TikTok star, Instagram starlet that's getting paid bukus of money to, you know, have something that's been pirated from a foreign country. So start those conversations early. And it's interesting, moms and dads are always super appreciative that they're not the one having that conversation, that it's us as the expert. And then give patients the ingredient list and that EWG app, and the ingredients, those ones that I have listed, that's in your handout. So make like a little card or a rat card, something that you can give to patients that has that information on there. And then, you know, talk about, here's how to clean your eyelash extensions. Utilize a little brush, utilize hypochlorous spray twice a day. Make sure that you actually wash them, and then take breaks in between getting fills so that they're not on there for I had a patient recently, and I'm cringed to even ask other patients, but she offered this information. She'd had them on for 3 years with no breaks. And then specific hygiene instructions, and that's going to be right here. Here's your lid and lash strategy. This is what the patient has to walk out with. Lids and lashes every night. We're washing with, making sure we're getting all that off. Utilize your hypochlorous spray to reduce that bacterial load. And then follow that up with a vetted serum and then a vetted sunscreen in the morning. They have to use sunscreen. They have to wear their sunglasses, because here's all the things that we're talking about that this can lead to. Something as simple as washing your eyelids and lashes can help prevent meibomian gland dysfunction, chalazia, dry eye disease, contact lens intolerance, lash extension use, ocular rosacea, and Demodex. So there is my contact information. I hope you guys had a good time. I had a blast.